Okay, so let's pick up with shock states. So when we're talking about shock, there's different types, but overall, the thing to remember with all of them is that there's something that has caused a critical decrease in tissue perfusion across the body. All right, this is either caused by a loss or redistribution of our intravascular fluid for some reason. When we start seeing organ failure related to shock, we call that MODS, or multi-organ dysfunction syndrome. Right? Something's going on that we can't adequately perfuse our tissues because blood flow is impaired. Right? What the signs and symptoms or manifestations we see of shock include inadequate tissue perfusion and then responses to our body trying to attempt to compensate. Right? So there's different types of shock. There is hypovolemic shock, cardiogenic shock, distributive shock, which includes neurogenic, anaphylactic, and septic, as well as obstructive shock, which means that something is preventing the heart from being able to fill and beat. All right, this can be from things like cardiac tamponade or a tension pneumothorax. They get their name based on what the cause of shock is, and we're going to talk about them more in depth. But hypovolemic, if we break that down, low volume, all right, so low volume is causing this type of shock. Cardiogenic, cardio starts, so this is some type of cardiac problem. Neurogenic, all right, nervous system problem. Anaphylactic has to do with allergic reactions. Septic has to do with an infection. All right, so let's look at these. When we look at hypovolemic shock, we have a diminished blood volume or we have a lot of blood loss. All right, this leads to inadequate filling of our vessels. We have our little infographic guy over here who's been stabbed and he's had excessive blood loss. Right, you can also have it if you have a lot of burn area and surface area of the skin impacted. All right, usually somebody has to lose between 15 to 20% of their overall volume to go into hypovolemic shock. It can be caused by hemorrhage, third spacing, burns, things like that. What we see is the body trying to compensate. It's going to increase the heart rate, increase the heart contractility, cause vasoconstriction to try and deter blood away from your periphery and keep it towards your organs that are more important. We activate the renin-angiotensin-aldosterone system as well as ADH to try and retain any fluid. Right, so we're not going to see people urinating. They're going to be trying to keep hold of all the fluid they can. And then as shock progresses, the vasoconstriction is going to become more severe, and it's going to shunt blood away from our non-essential organs like the surface of our skin, right, and keep it towards our core. And then as it progresses even further, it's going to start prioritizing which organs get our blood flow as well. So we'll start shutting down blood flow to things like our kidneys and our intestines and our abdominal organs because it wants to shunt blood to the heart and brain to try and preserve them as long as possible. Things we see, we're going to see early on an increase in heart rate. That's the body trying to compensate. Right, we'll see a decreased blood pressure because we don't have enough blood. All right, so it's going to be low. Decreased urine output. Patients are usually going to have a change of level of consciousness, and this will get worse as it progresses, where they're confused, disoriented. They may not be able to be aroused or woken up. Lab values, you're going to see a decreased H&H. Lactic levels are going to increase, and we're going to end up with an acidosis in our pH. Their pulse is going to be thready because the vasoconstriction is making it difficult for you to be able to feel it. And the extremities and the skin is going to be cool and clammy and pale. Right? Their preload's going to drop. Their afterload's going to increase because of the hypertension, right, and the vasoconstriction, and the contractility is going to go up to try and compensate. So when we think about hypovolemic shock, what do you think is our initial treatment? Right, we have to give them volume. All right, so we'll give them IV fluids. Usually we start with normal saline, and then as soon as we can, we give them blood products to try and replace their blood volume for them. In cardiogenic shock, now something is impairing the heart's ability to pump. All right, the blood cannot get ejected from the heart. There's a failure to eject blood from the left ventricle, so that means our cardiac output goes down, and then our blood pressure goes down. Usually this is caused by a heart attack or myocardial infarction. There can be extreme manifestations of heart failure as well if it's not treated properly. Whenever we look at treatment, right, we're looking at vasodilators to try and open up our blood vessels to decrease our afterload. Ionotropic medications help with the heart beating, right? They may need an intra-aortic balloon pump that's going to decrease afterload by widening the aorta diameter. They may need a ventricular assist device, or a VAD, that's going to take over some of the pumping work of the heart for them. And it could mean that they need a heart transplant if we can't get them back to cardiac function that can sustain their homeostasis. In distributive shock, something has happened where we still have normal volume of circulation in the blood, but the issue is that the vessels are now too relaxed. So blood is pulling and distributing in areas where it shouldn't be, right? And it's not getting pumped back to the heart and to the core like it should. Mainly, it's because something has triggered a massive vasodilation. So the blood pulls in vessels instead of getting pumped throughout the body, right? This can be from a neurologic cause or neurogenic, where we have sympathetic innervation of the vessels that's off, right? And they're not constricting like they should, so they just dilate. An anaphylactic reaction, like if somebody has a severe allergy, they're going to have a severe vasodilator response. And then septic shock is caused by an infection. So a massive infection where the agents are releasing endotoxins, and then those endotoxins get into the systemic circulation and cause a massive vasodilation. In obstructive shock, we're talking about something that's blocking the great vessels of the heart, or the main artery branches of the heart, from being able to provide blood flow to it. And then the heart can't function. This is caused by severe complications like an aortic dissection, where the aorta has an aneurysm or a weakened area, and the aorta essentially ruptures and breaks apart, and blood pours out instead of going to the heart. Okay. Cardiac tamponade is where there's fluid around the sac that holds the heart, and if it fills up too much, then the heart doesn't have ability to move, right? And that can cause obstructive shock. A tension pneumothorax is where somebody's lung has collapsed. Pneumo means lung, right? And it has filled the thoracic cavity, and it's putting tension on the heart so that it cannot expand. And then a pulmonary embolism is where a clot or an air bubble or something has gotten into the pulmonary circulation and gotten stuck, and it's obstructing blood flow. This is just a table. Some students like to look at everything in one area. That gives you comparison between the different types of shock and how the patients might present. If you like to do that, you can review that for studying. Right. Next up, we're just going to talk about blood pressure. Right, so we have arterial blood pressure. What happens is that your heart beats in a rhythmic pattern, right? And your blood pressure reflects this pattern, right? From how blood goes through the heart from the left ventricle and into the aorta. It rises with contraction. That's how we get our systolic or systole number, right? It should be less than 120 milligrams of mercury. The lower number measures how much pressure is in the heart during relaxation when it's filling. That's diastole, and it should be less than 80. Pulse pressure is where we're measuring the difference between the systolic and diastolic numbers, right? Mean arterial pressure is the average pressure of your systolic and diastolic numbers, right? It's an indication of tissue perfusion, right? Pulse pressure tells us about workload of the heart. All right, and you just literally subtract your diastolic from your systolic, so 120 minus 80. All right, and mean arterial pressure we care about because that tells us about how our perfusion is going. This is just a diagram to tell you about how things are measured. So overall, you'll always have at least your diastolic pressure in your heart. When we go through a contraction, all right, it will go highest to your systolic pressure. You might even hear that extra sound, right, as it comes down, and you're listening, right? The mean arterial pressure is the mean average pressure between the two. The pulse pressure is the difference between your systolic and your diastolic. to regulate blood pressure. All right, your body does this without you thinking about it, right? You're not there sitting thinking, I need to take my blood pressure down, 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 down. Oh, well, we need to come back up. All right. It's controlled in your brainstem. All right, it's a neurological autonomic system function. All right, the brainstem, anything in your brainstem, you don't control, you don't think about. That's the same as your breathing and your heart rate. All right. It gets controlled through your parasympathetic nervous system with the vagus nerve, and the sympathetic nervous system through the spinal cord and your peripheral sympathetic nerves. All right, your sympathetic nervous system is in charge of causing stimulation and vasoconstriction, so that will bring your blood pressure up. And your parasympathetic nervous system is in charge of relaxing it or bringing it back down, so they work together. Your autonomic nervous system gets mediated by chemoreceptors and baroreceptors. All right, you can also get some short-term regulation of the blood vessels through hormones, such as the renin-angiotensin-aldosterone system as well. All right, so baroreceptors and chemoreceptors. Baroreceptors measure pressure. All right, think barometer like the weather and the air pressure. All right, baroreceptors measure pressure in the vessel walls and heart. All right, they're mostly in your carotids and aortic arch. They respond to changes in how much the vessel wall is stretched. All right, if it gets overstretched, that signals that the pressure is high in our vessels, sends an impulse to the brainstem for the stimulation of heart rate and vessel tone to change. Chemoreceptors, think chemical chemo, they respond to changes in gases like oxygen, carbon dioxide, as well as hydrogen ion content in our blood. All right, they're also in our carotid, our aorta, and our medulla. All right, they mainly use our respirations to control our heart rate and our blood pressure, all right, but they can also induce vasoconstriction as well. Hormones, or humoral control of blood pressure, it can be done with the renin-angiotensin-aldosterone mechanism. Epinephrine is a sympathetic neurotransmitter. It's most commonly associated with your fight or flight response. It gets secreted from the adrenal glands. Just think about the reaction you have as you get scared or startled suddenly and how your heart rate jumps up, right, and you can feel your heart beating for you. All right, that is a signal, right, that you have stimulated your epinephrine release. All right. Vasopressin can also be known as antidiuretic hormone. All right, this is released from the pituitary gland in response to changes in blood volume, or BP. All right, so for instance, if your body sees, you know what, we're kind of dry, it's going to release ADH to hold on to fluid. All right, it can also have a vasoconstrictor effect, but that's pretty short term. It doesn't last long. This is just a diagram of the different ways that we activate the humoral control of blood pressure that you can review. That summarizes what we just talked about. Another very common problem with our circulation in our cardiac system is hypertension. So it's a leading risk factor for all of our other cardiovascular diseases like stroke and heart attack. We call it the silent killer because usually you don't know a patient has it unless they're getting their blood pressure checked or it's causing other problems. It affects about 50 million people in the U.S. Men are at greater risk than women. Women, after they go through menopause, usually about 45 years old, are also at increased risk. African Americans are at greater risk than Caucasians. They tend to have an earlier onset and more severe effects from it. The older we get, the more risk we are. Also, people who have a high diet, lack physical activity, or consume too much alcohol and are obese or at risk. We classify high blood pressure based on this table. All right, now, either number off, systolic or diastolic, is important to know that can classify you. So in other words, if you have a blood pressure 120 over 89, you would be pre-hypertension. All right, if you have a blood pressure of 152, all right, over 89, you would be stage 1 hypertension. You go by the highest number and which one's abnormal. You only need one abnormal on either side to be classified. All right, so you want to review this table and remember those guidelines. All right. Primary hypertension is also known as essential hypertension, and we're going to pick up here with your next set of slides.